I want to talk about incomplete caries removal. I want to bring you a sort of state of the science update on incomplete caries removal. And I want to start by showing this radiograph, and please ignore the calculus hanging off of every tooth. And let's tooth number 30. And if you saw this radiograph associated with a patient sitting in your chair, I ask you, what might you start anticipating you might have to do? A pulp cap, a pulpotomy, perhaps endodontic treatment, other referral, or doing it yourself? But if the patient has a deep lesion such as that one half the dentin thickness or greater, but no signs of irreversible pulpitis, and that means it's positive to a cold test, it's negative to percussion, there's no spontaneous pain reported by the patient, and no periapical lesion evident in any radiograph that you have, then the science, the evidence suggests that you ought to consider incomplete caries removal.
Some people are doing stepwise already because stepwise was advocated and taught by school. And so in that respect, it's not as though it is a contraindication or it is contrary to what you were taught, since it was something that was advocated in school. What we think is that we should probably go ahead and look at longer term studies, but the question would comes in is, how long do we need? And the rate of caries differs from person to person. So knowing when the bacteria is inactive in one person doesn't necessarily make it inactive in another. And so there's just all these questions.
That was the suggestion made by one of our table participants, was to maybe think of that as an opportunity for the network to provide a service to its members, and seeing if we could link up some type of better access to full journals, so that when there is a more controversial issue, they can really investigate the full article to see whether they feel as comfortable with it as possible. So I thought that was an important
So we
issue.
talked about a couple of the barriers that weren't mentioned before, and that actually dominated most of our discussion, even though we were charged with number 4. A couple barriers we talked about was, in terms of adapting something new, was the difficulty given the practice setting you were in and the philosophy that was there. So whether you were in an educational setting that was predominated by older, less evidence thinking, or a group practice that maybe you as an individual practitioner weren't allowed or able to influence the immediate treatment decision or philosophy, I guess, of that setting.